Hi everyone. We're going to be talking about troubleshooting the IA and failure. We're going to be going over the depth of the needle, the height of the target. You'll see that the clinical pictures are from my personal collection and the concept itself was created by myself. I'm primary author. I'm MJ Fehrenbach, RDH-MS, and this is in conjunction with the clinician J. Young Scholes. She's retired now, RDH, ASC, and she's at rdh.edu. Let's go ahead and see what's happening. Here we are together. Hey, how you doing, Joyce? Margaret says hi. Now, again, the figures themselves are taken from Illustrated Anatomy of the Head and Neck. Make sure you have the latest edition. You want the 6th edition. It's an anniversary edition. That means it's 25 years plus in the making and the doing. And that's 2021. Again, from W.B. Saunders / Elsevier. There I am with Mr. Bones. Hey, Mr. Bones. Now, we all know there's substantial variation, oh boy, isn't there, that exists in the anatomy of the landmarks of the mandible and its nerves compared with similar structures in the maxilla, so it complicates our mandibular anesthesia. Thus the need for this troubleshooting of cases. Now, how many cases will you get that will consider this? Some of them you won't get as many as others, and we'll go over that, but some of them you'll get quite often. Now, if we have troubleshooting and we don't just get that done, we're going to have lack of clinical effectiveness of anesthetic administered for the mandible. And you know, people just clean the front of their teeth. Those molars, and even the premolars, we need them to be numb. Not just for pain control, that's really important, but also for hemostatic control. And this sure is true of the IA block, isn't it? The first thing we're going to go over is the depth of the needle. This has a lot to do with the length of the jaw. Not a lot of textbooks, even mine, talk about this at this time. You can only do so much. So this is kind of something that maybe we haven't discussed before, but maybe you've noticed it as you're giving local anesthesia. So now let's look over that depth of the needle. Now, this is average here. We all know what average is. You see it, and it's a nice day. But not every day do you see it, right? Because average is average. We're going to see more complications. That's why we're talking about troubleshooting here. So the target area for the IA block is at the depth of the pterygomandibular space on the medial border or inside or lingual of the mandibular ramus at the correct depth for the injection. The average depth, what is it? Into that soft tissue. Remember, we want to go soft tissue because we'll talk about that in just a moment, is 20 to 25 millimeters, approximately 2/3 to 3/4 the length of a long needle. We'll get in that right away. We want to go until we contact bone. Now, gently go in, nice and smooth. We talked about that in the velvet touch in some of my seminars across the United States. If you don't know that, go over to my local anesthesia page, all LA, off my website, dhed.net, and check out that velvet touch. It's the most read article in the last few years from RDH magazine. Whoa, I'm happy about that one. I want everyone to have that velvet touch. So again, the needle gauge and length, we want to use a 25 gauge and we want it to be long. Why? A smaller diameter gauge would not provide reliable aspiration. Remember, this is the number one after the PSA. Again, number one on the mandible. after the PSA, because that's on the maxilla, that has positive aspiration. We want to make sure that we have that reliable aspiration so we're not injecting into the blood vessels. And a short needle, we're going to be seeing it would be dangerously inserted to its hub in many cases. Sometimes you might be able to get away with it, but you don't know until you look, and sometimes as you go in. Now again, here we have that average, but we want to go into more detail here. Now, this detail was only added in this last edition. It was a focus into that entry, that sweet spot that we all know exists there. Make sure you look for it. It is the pterygotemporal depression. So the pterygotemporal depression. So it has something to do with pterygo, something to do with temporal, and it's a depression. Now, many people, when they're putting their topical on, will look for this sweet spot, and we'll talk about that in just a moment. Again, gentle contact, we talked about that on the medial surface of the ramus, and then the injection is administered, not until then. So again, pterygotemporal depression. Let's look at some ways we can see it clinically. Here's, it's like a hollow. It's between the medial pterygoid muscle, there's the pterygoid part, and the laterally located tendon of the temporalis muscle. Thus the name, hence the name. Sounds fancy. Notice at the top here, on this one figure here, we're kind of looking for that sweet spot. Make sure you retract. If you have any difficulty, again, get some assistance with retraction. We want to be able to have that tongue not laying in our sweet spot. Now, in the second figure, again, these are from my personal collection, I put a little of that dye, that you check the denture with, in the area of the pterygotemporal depression. Look at that sweet spot. It varies in how it looks. So let's talk about that. Here again is the area. Now, a hematoma is filling the pterygotemporal depression. It's a possible risk of local anesthesia. So there was the sweet spot. Notice it can change in how it looks. So let's talk at length about that just next. Remember to let your patient know about this possible risk. There may be some discomfort in the area, but again, the body will remove that blood vessel material, the hematoma. It is a risk. Don't let it excite you. We make sure that always to avoid too much of this. Again, with some people with their health history, we can't avoid it. Maybe they don't know that they have a bleeding disorder. Maybe they're taking medications that promote bleeding. Sometimes they don't tell us everything. Remember to update your health history. Also, again, use that, long and 25 gauge. Make sure you're using that. So it serves as a visible landmark for the needle entry. Not is it the only one? This, remember, is soft tissue. We want to first look for those hard, landmarks. And we've already gone over that in the textbook. Let's now move to the next thing and talk about what does that pterygotemporal depression look like? Well, I think it mimics an inverted teardrop. Now, the reason why I do that is because some people think it's triangular shaped. But in many cases, you'll see it as just, a rounder thing, sometimes oblong. It depends, again, on the patient. Here we're using a topical, slight pressure. You can also use the tip of the needle right before you enter. So again, topical, you can check it out. Make sure you keep your topical there for 3 minutes. I know they say 1 minute on the outside of the thing, but if you look closely at the MSDS, it says 3 minutes. I like that 3 minutes. It's relaxing the patient. It's relaxing me. Again, slight pressure with the tip of the needle can be used right before you go in. So again, you want to go in the superior basal part or near to its posterior position base. I find that again, prevents that masseter muscle from being in my way, and it prevents, again, the depth. I'm getting that. Let's look over the next thing. Where are we located here? Well, look here. We've got the auriculotemporal nerve here. We've got the mandibular nerve. We've got the lingual nerve. Here's that IA nerve. Remember, when we do the IA nerve, through through over time, the lingual nerve will be numb. Make sure that you go for the IA nerve. You want to do the whole amount of the injection material. You don't have to stop and do the lingual nerve, okay? There's that whole plexus that we're going to numb. It's going to be fantastic. So here's the needle, again, on a certain type of section here. We've got the lateral or right side, medial or left side, posterior and anterior. I've added those because I don't know. Sometimes when I look at a figure, I go, where the heck is that? Again, there's that masseter muscle. Oh my goodness. There's the coronoid notch. Remember, that's that hard tissue one. There's the temporalis. Again, we want to be able to get around that temporalis muscle. There's that medial surface or inner, and there's that sweet spot of the IA. Notice again, there's the lingual. We're going to get it. It will, again, saturate the lingual nerve. We're going through, again, the pterygomandibular raphe. Let's look at the next thing. I wonder who this is. She's got a famous actress daughter, and she was famous actress herself. She was on that real funny show, which I probably shouldn't mention, Laughing. Okay, she's got an incredible, even though she's kind of small, she's dinky, very dinky. Oh, she's a sweet little thing, really a sweet, sweet woman. And her daughter, wow, fantastic actress, both of them. But she has a very long jaw length. Equals a longer depth of the needle will need to enter to reach its target. Kind of makes sense. You're going down that road, it's going to be a far piece before you get to the end of that road. So less of the needle is seen. Let's now, and again, that's an internet pickup. Notice I protected the identity of the actress. Here's real world. Deep depth of a long jaw, an incredibly long jaw. I think it's actually longer than the actress that we just had. So long jaw length equals longer depth with a needle. It'll be need to enter to reach its target. So you're going to see less of the needle. So let's look at that. Here's our long jaw. And again, here's our depth over on the right side here. You can see it's amazing. So again, add this to your repertoire. Deep depth, long jaw, less of the needle is seen. Well, what about the other side of the world where someone has a short jaw length? Now, this is another actress, and I live in Seattle, hint, hint, and sometimes I am a little sleepless. This is a short jaw length. It equals short depth of the needle, which will need to enter to reach its target. So more of that needle is going to be seen. And this is an internet pickup picture. I protected the actress's identity. Here's from the real world. Very shallow depth with short jaw. Look how short that jaw is. So short jaw length equals a shorter depth of the needle will need to go to enter to reach its target. More of the needle is seen. So again, short depth, more of the needle is seen. Shallow depth with short jaw. Shallow depth with short jaw. Is everybody all set on that? So again, that is talking about depth and jaw length. Let's go to our next topic, our secondary topic today. This is the height of the target. And this then talks about the height of the ramus. Remember, the ramus is that extension from the lateral, it's the lateral part or horizontal part of the mandible. The ramus is that vertical extension. Let's look at that. Here again is average, as we said. The target area for the IABOC average is the inferior villar nerve exiting the mandibular foramen on the medial surface of the mandibular ramus. It's overhung anteriorly by the lingula. But geez, the last time I remember, I haven't skinned anybody to go do my local anesthesia. These are hard tissue, bony landmarks. They're important, but let's now talk about some soft tissue ones. Remember, there's going to be a lot of variation, not only in the hard, bony landmarks, but also in the soft tissue. But we want to get going on this height. Now, the target area is the pterygomandibular space, as we said, on the medial border of the ramus at the correct height for the injection. But how do we do that? Well, now you have to go back to the book. The only one that we're going to be talking about right now is the horizontal line. On the vertical line, you'll have to get that from the textbook. So today, again, the intersection of somewhat imaginary lines further is discussed in the textbook. So today, we're going to palpate the coronoid notch mentally. We're going to go for the greatest depression on the anterior border of that mandibular ramus. To determine it, it does help to visualize this imaginary, somewhat horizontal line that extends posteriorly from the coronoid notch to the pterygomandibular fold. As it turns upward or superiorly towards the soft palate, it demarcates the posterior border of the ramus. It really does, and you can see that in the yellow dash line there. Again, that's that pterygomandibular fold. And then we've put in purple, if you can see there, we have the posterior border of the ramus, and that's more to the reader's right. To the reader's left there, what do we have? We have that again, that coronoid notch that we're palpating. I like this finger retraction. I like to use 2 fingers, not just one. Again, a finger on one side, thumb on the other. Look at the textbook for more information on that. So what nerve are we numbing here? Okay, this is another view. I want to put this view in, but as you can see, there is then the inferior alveolar nerve. You can see that depth, and we need to play with that. Where's the height? Look how long that nerve is. How am I going to get my height? Well, one thing I'm going to do is that it's an intersection. These are slightly oblique lateral views. Again, look at that over on one side, then put it together with the real world on the right side. Look at the angle of the mandible. Look at your mandibular notch. Then go over and see that condyle. Then your coronoid process, your coronoid notch, that's what we're going to go up and down to feel that. Okay, so we're on the ball. Let's look again. Take away the soft tissue and look. Again, we're talking about that horizontal line. Now, it's also, we talked about, it's the depth of the coronoid notch. It also is parallel to and approximately 6 to 10 millimeters. That isn't very much. Superior to the mandibular occlusal plane in the majority of adults. In children, depending on the age, that varies. It can be right at the occlusal plane. Or if you have a more mature child, again, moving to the preteens and teens, kind of pre-adult, you'll see that that gradually goes more superior to then you have the majority of adults. Geez, haven't we seen this masked actress before? Oh yeah. Now, she may have had a long jaw, but her ramus, whoa, it's short. I see this so often, is the short ramus. Incredible. The vertical height there is incredibly short. So short ramus equals a target that seems really high. You may be even close to the maxillary molars. In one case, I could not give an injection. I tried and tried. The maxillary molars were in my way. It's only happened once with me of all the injections I've ever given. So just once. So I asked her. And it was a peer that I was working on. Because the student dental hygienist couldn't do it, I thought, well, let me just see if I can get close to them, the sweet spot. No, man, that ramus was so short. She'd had orthodontia, and maybe some things happened. We all know, again, that can happen. So again, I can't say that case was how she was born with. But, couldn't get it. And you'll have in life. Now, from the real world, here's a short ramus. Notice that long jaw. Now, in some people, you'll have short jaw, short ramus. This one, long jaw, but we're concentrating that short ramus. The target will seem really high. Look, oh my goodness, I'm right by the maxillary molars. Again, so close, so incredible close. So there's your sweet spot. There's your temporal depression. But look how close it is. Now the next case will be what? It'll be what? Further inferior or further down. Every case is different. That's what makes this exciting. Now, will the right side be the same as the left? Will the left be the same as the right? No. And I remember in a class where somebody stood up and said, I can't take it. Why aren't people symmetrical? And I said, I don't know. And when she sat down, I had to kind of look away. She was not symmetrical at all in her facial features. I was like, whoa, okay. So, yeah, we learn, don't we? I wanted to kind of say, go look in the mirror, but I am a sweet, nice thing, aren't I? Okay. Oh, here's that actress again. Oh, geez Louise. Okay, height of target, height of ramus. This one is long. Okay, remember we said she had a short jaw, but remember you can have a long or short jaw with a long or short ramus. A long ramus height equals target that seems incredibly lower. It's so far away from the maxillary molars, you think you're given what? A buccal injection. No, you're not. And don't think buccal. I know some people are talking about it. It may be an infiltration of the PDL, but a true buccal injection, and we need that because of furcations. I need pain control there, and I certain darn tootin' need what? Hemostatic control for those, again, the buccal of 1, 2, 3 molars, first, second, and third. And people are keeping their thirds now. So from the real world here, what do we have? Long ramus. Notice short jaw, but you can have both. You can have a long and a long. The target again seems much lower. Look how low that is. I mean, you feel like you're on top of the occlusal surface of whatever molar you're there. It's going to be so far away from the maxillary molars. So I hope this has helped you, again, achieve that extra special sweetness of troubleshooting. Make sure you check out the textbook for your common and useful, again, troubleshooting of the IA block. This, again, is the icing on the cake. I hope everybody enjoyed this, and we'll see you soon. Bye.